Well, hello everybody. I have the record button going. That's my cue, so let's get started. Thank you everybody for joining this February Global Health, Nutrition, and HIV Community of Practice WebEx. My name is NICeRAcE, and I am your World Vision Global Health COP manager, and thanks for attending today. So today we are talking to World Vision Niger and World Vision Canada on the NICeRAcE program. Actually, I don't know if that's exactly how they say it in their acronyms. We'll find out. But the acronym stands for the Niger Integrated Child Health Services Rapid Access Expansion Program, and it is using community health services to save the lives of children in hard-to-reach areas of Niger. So we have the speaker introduction. I'm going to leave that to Patsy to take over and do that. Just a few housekeeping announcements. As always, you might have noticed that you were muted when you came into this WebEx. That's to keep our background noise to a minimum. I just ask that you please stay muted until we get to the Q&A. As this is an internal WebEx, we should be able to have time for people to unmute and mute during Q&A. But while the presentations are happening, please stay muted. I'll put this up just in case as people are talking, just to make sure that everybody can get connected here in the next couple of minutes. But while I say please stay muted, by no means do we want you to be silent. I invite you and encourage you to please utilize the chat box that we have to ask your questions and make your comments to our speakers as they present. I'll be watching that chat box and monitoring it so that we'll start with those chat box questions first when we get to the Q&A portion of the WebEx. Just a tip, please change the send to box to everyone so that everyone can participate in the chat. The default is set just to send to me. I haven't figured out how to change that yet, but there's my tip. So please, let's get our fingers warmed up and introduce yourself. So type in what is your role within World Vision and where you're calling in from today. So do a bit of an introduction, and I'm going to move our slides over so we can see our speakers and hand it over to Patsy. So Patsy from World Vision Canada, tell us a little bit about why we're here today. Why are we presenting this NICeRAcE study?
All right, thank you so much, Sarah. So I'm the grant manager for the NICeRAcE project, and I'll give you a little bit of a bio about me and about my other colleagues presenting today in just a few minutes. But the NICeRAcE project is a project funded by the Global Affairs Canada through the direction and leadership of the World Health Organization. And World Vision Niger and World Vision Canada were sub-grantees of this project. So the project started in 2013 and is coming to a close in March of 2018. And so as we're coming to the end, we just thought this would be about the project and its successes and things that we can learn from it, so that as a whole, World Vision can be and do good projects based on learning from others. So if I can just give a brief introduction of myself and of So my name is Patsy Orkar, as I had mentioned earlier. I have been with World Vision Canada since 2013, and I joined on as the grant manager for this NICeRACE project. My training is actually in organizational leadership and development, and I have over 15 years of community and organizational development experience both in Africa and also in Haiti. My colleague who will be sharing also about the project, the specifics of the project, is Grace Inganga. She is a nurse by training and has over 6 years of experience in community development work. She began her work with World Vision Niger in 2016 and in her current role as the field project manager for the NICeRACE project. And then also joining us in the presentation is Dr. David Zakis. He is a professor of distinction in global health in the School of Occupational and Public Health, Faculty of Community Services at Ryerson University in downtown Toronto, Canada. His current research, teaching, and service activities focus on international and global health, primary health care, maternal and child health, health system and organizational development, management and reform, community-based health services and promotion, community participation, e-health solutions, education, and environmental sustainability. He has extensive knowledge and experience in academia, non-governmental organizations, and multilateral institutions, having occupied senior roles within each. Current projects and collaborations are in Niger, Mozambique, Ethiopia, Uganda, Rwanda, Laos, China, and Canada. So David will be speaking particularly about some research that we did around mobile health technology and an app that was utilized for iCCM. So I will continue on then and start with our presentation. So the NICeRACE project, as Sarah said and pronounced it correctly, NICE stands for Niger Integrated Child Health Services, and that was the name chosen during the proposal process of this project. And the actual funding is through the RACE project, which is the Rapid Access Expansion Program that was in collaboration with WHO and Global Affairs Canada. So the two main objectives for this project were to contribute to the reduction of child mortality by increasing access to treatment for common childhood illnesses, particularly pneumonia, diarrhea, and malaria. This was to happen in 4 health districts in Niger, targeting 230,833 children between the ages of 2 to 59 months. The second objective was to stimulate policy updates and catalyze scale-up of Integrated Community Case Management, or iCCM. So the Integrated Community Case Management is a strategy to extend case management of childhood illness beyond health facilities to villages so that more children have access to life-saving treatments. In our project in Niger, we were looking at communities that were a minimum of 5 kilometers from the closest health center. Majority of our communities were between 5 to 10 kilometers, but there were some communities that were 25 to 30 kilometers away. A little bit about Niger. So although Niger has made a lot of effort in reducing the number of child deaths of children under 5. Since 1990, there has been a reduction of 61%. But despite that, there are still too many deaths. According to the defined country indicators for Niger, there are 126 to 1,000 live births. And 2/3 of these deaths are caused by malaria, pneumonia, and diarrhea. So in 2012, there was a meeting held by health officials in various countries in West Africa to discuss how to address the mortality rates of children under 5. And as a result of this meeting, WHO and UNICEF wrote up a statement where they supported iCCM as the methodology that they felt would best address this issue. And so as a result of that, the RACE project came to light. And so World Vision Niger and World Vision Canada worked together to apply for this funding, and were granted in 2013. So some other statistics about Niger, so we can get a sense of the population. So there's 19 million plus population in the country, 83% rural, and 66% in poverty. Niger has one of the lowest, actually the second lowest, HDI index of 0.353. And they also have a high under 5 mortality rate, as I mentioned earlier, of 126 to 1,000 live births, of which, again, 60% are caused by malaria, diarrhea, and pneumonia. There's a rapid demographic growth, a 7.4 total fertility rate, and 3.9 annual population growth. There's also a low health coverage. So in the districts where we have been working, in Doso, there's a 45.86%, and in Tawa, there's a 46.89%, whereas the national coverage is 48%. So the areas were chosen because of the great need for increased coverage. And again, there's a high maternal mortality rate as well of 593 of 100,000. This slide just gives a little bit of a demonstration of where the regions and the districts where the NICeRACE project took place. So we were in 2 regions of Doso and Keita, and in 4 districts, Boboy, Doso, Duchi, and Keita. These are some of the high-level achievements that we were able to arrive at nearing the end of the project. So there was 1,313 community health workers trained, or locally they're referred to as RCOMs. And these were the local volunteers that were trained to actually diagnose and treat the children. There was 1,216 villages covered in the project, 509 Ministry of Health staff who were trained in iCCM. There was 200 community representatives trained on drug management, and these representatives are a particular local committee that is formed to look specifically at drug management for their community. And so this was a structure that existed already, but our project saw that this particular group would be a great entry point as those who can continue the management and the upkeep of the distribution of drugs even after the close of the project. So it was part of our strategy to train these individuals who could continue to be in the community and continue to manage the use of these drugs so that they wouldn't get taken up into other health activities. In terms of specific outcomes, there were 496,525 rapid diagnostic tests done. There was 319,722 simple malaria cases treated. There was 244,994 pneumonia cases treated. 157,477 diarrhea cases treated. 16,660 severe cases referred, and these were cases of malaria, diarrhea, or pneumonia. And then 31,219 cases referred for malnutrition. So the volunteers were trained to do the initial assessment, but if the malnutrition was deemed severe, then they would refer these cases. So that is a general overview of the actual project. Now I will hand over to my colleague Grace, who will continue to discuss more of the baseline and the end-line survey results.
So good afternoon and good morning, everyone. As Patsy has introduced me, I'm Grace, the RACE Project Manager. And before I start with this slide, I just want to complete or just add on to what Patsy talked about, gave a background of RACE. And I just want to say that RACE is, it was or is a pilot project. And it's the first project in Niger to implement iCCM. Through political will and looking into the high mortality rates in Niger, the government of Niger felt that they needed to try the strategy of putting ARCOMs, or rather community health workers, who we call relais communautaire here in Niger. So you'll hear me use that word ARCOM a lot, but it just means CHW, community health worker. So the government of Niger felt that they wanted to try this strategy, to pilot it and see what results it would give, and to catalyze scale up if the results were good. So this particular slide gives some results from the household survey that was done last year, actually end of 2016, as we started implementing in 2013. So these results show that 99% of caregivers knew that the ARCOM worked in their community. So this talks about the knowledge and the awareness and appreciation of the community health worker by the community. 77% of caregivers knew the role of the ARCOM in their community. So there was no baseline for these particular indicators because ARCOMs were not present in the villages at the beginning. So this is after implementation what the end-line survey said, household survey. 86% of cases of illness among children ages 2 to 59 months were taken to an ARCOM as the first source. So out of the population, 86% of the population in the villages of intervention were going to the community health worker as the first source of care. 81% of caregivers knew of 2 or more signs of childhood illness that required immediate assessment, which is quite high for knowledge. 98% of ARCOMs believed that of caregivers believed that ARCOMs provided high quality services. So we see here the ARCOM has become quite a trusted healthcare provider in the village. 91% of caregivers of sick children who were referred to a health facility by an ARCOM adhered to the referral advice. So those cases that the ARCOM could not treat had to be referred, and 91% of caregivers adhered to this advice, showing that they were trusted enough for the caregivers to kind of obey what they were asked to do. And then in the yellow box up there, the care seeking increased from 69% at baseline to 85% at endline. I just want to say that the baseline levels here of 69% are a bit inflated because when the sampling was being done at baseline, there was no consideration of if there was a case de santé, which is the lowest level of dispensary in the community level. There was no consideration of the distance of the villages. So that's why that number looks high. But otherwise, the national average is 53% of care-seeking behavior. So having moved that up to 85% is quite impressive. We find that quite significant. So here, this is what the treatment rate for the routine monitoring data for diarrhea treatment, 98%, malaria treatment, 64%, pneumonia, 74%. So overall average treatment rate at 72%. And these rates, they're calculated regardless of the outcome of the treatment. So these are not rates for recovery. Did the child recover from treatment? This is just regardless of the outcome. So if I could just mention the national average treatment rates, like for malaria, I think is 15% per DHS. This is in 2012. So 64% is quite impressive, showing evidence and results of this particular project. So moving on to the next slide, we conducted a list assessment, the life-saving tools, the list model estimated results based on the total population of the 4 project districts. And I need to say that this was in collaboration with a consultant, ICF, who were hired by WHO to help carry out this model. And so the estimated change in under 5 mortality rate, as that was one of the objectives of this project, showed a reduction of 17 deaths per 100 live births. And that would bring us to a 13% decrease in under 5 mortality rate from 2013 to 2016. So just in 3 years, a reduction, a decrease by 13%. And that just shows per year what the under 5 mortality rate was and how it reduced to 2016, from 2013 to 2016. So from 137 deaths per 1,000 live births to 120 deaths per 1,000 live births. So the estimated lives saved in project areas, an estimated total of 1,128 under 5 lives saved by pneumonia, diarrhea, and malaria treatment. This is, like I mentioned, in a 3-year span. And an estimated 965 lives were saved through the treatment of ARCOM, or community health workers. So we see a number here, total lives saved among children, 1 to 59 months. This is by all interventions in the implementation areas. Then through the treatment of the 3 pathologies in those intervention areas, these are the number of lives saved. But the contribution of the ARCOMs through the treatment they provided, it's 965 lives, showing that the ARCOM has quite a high percentage of contribution in the lives saved during this period by their intervention. And the difference there is just due to treatment provided by, other health providers, which is now the health system. This slide here is it just talks about the Niger under 5 mortality rates versus the neonatal, but we'll mainly concentrate on the under 5 mortality rates. And it shows the current national annual average rate of reduction at 4.9. And so based on RACE results, we saw that there was a reduction of 13% throughout the 3 years, which would bring us to an annual average rate of reduction of 4.3. And the AAR needed to reach the Sustainable Development Goal target, 2015 to 2030, we see here is 9.3%. So if iCCM was scaled up nationally, we're just making an assumption, as an independent addition, the annual average reduction rate would come up to 9.2, and it would actually bring us to meet the SDG target. So it just goes to show how effective iCCM is in these kinds of settings. This is a slide showing the national scale-up perspective. Like I said, RACE is a pilot project, which sparked a lot of attention in the implementers community, which led UNICEF to do this mapping exercise and to figure out in Niger, how many community health workers do we have or do we plan to have practicing iCCM, implementing iCCM. And the white area is the non-covered area, meaning no partner, or there's no partner who has targeted these areas for intervention. The blue is UNICEF, with the help of Global Fund, have targeted the blue areas. And then the pink area is what RACE, what World Vision and WHO covered. And this just brings us to 15% of iCCM national coverage. Actual is lower because UNICEF has not yet covered all their targeted areas. And it just goes to show that we still have a long journey that we have just started, that RACE has actually started. But it shows that RACE has sparked some awareness, has sparked some interest, and that's why partners are even doing a mapping exercise to see where we are and where we need to go. So another one of RACE's great achievements has been iCCM policy update. The 3 main policy updates that have happened and are happening through the lifespan of this project. One, the installation of a national iCCM coordination team. One of the RACE objectives, as I said, was to stimulate policy updates. And RACE installed a national technical committee, which proved to be successful in its function. And so this catalyzed the installation of a national iCCM coordination team, which has now been signed into existence by the Minister of Health and is now functional, having held its first meeting. So there'll be a platform, to advocate for iCCM scale-up and iCCM reform. Another one of the policy updates has been there'll be a validation of the iCCM roadmap to sustainability. The iCCM roadmap and the scale-up, the validation of the scale-up national strategy. The national strategy and the roadmap were elaborated through RACE funds, and these documents will actually be validated by Ministry of Health in the next 2 coming days. So this strategic plan for scaling up it's a strategic plan to 2021, and the sustainability plan goes up to 2026. So this just goes to show that there's political will to further the iCCM agenda in this country, and that there is a roadmap to sustainability, and that the country, or rather government, Ministry of Health, is looking to scale up. So that's been one of the great achievements of this project. Well, I believe everything has sounded so rosy, but we did have some challenges in implementation. For example, one of the challenges we had, I'll just highlight a few: the recruitment of community health workers who meet criteria. So the criteria was that each community health worker can read and write. If anyone knows about the literacy rates here in Niger, they are quite low, and especially in women. So we were only able to recruit about 30% representation of women, the female gender, and that was mainly because of the low literacy rate, especially in women, which is about 15%. So that has been and is still a challenge, but I'm proud to say that it did not stop us from looking deep and looking hard and still getting coverage as we did, and being able to train over 1,000 community health workers. Another challenge initially that we've been able to overcome now is the coordination of partners. Like I said, race sparked a lot of interest, and so partners wanted to implement. And when they started to implement, there was no coordination. So with time, like I said, we've been able to overcome that by now implementing the national coordination committee, which will now regulate that coordination work. There will be a platform to discuss, and there'll be a platform for every partner to be up to date with the way iCCM needs to be implemented in Niger. Another one of our great challenges was supply chain drug management. This is not new to iCCM. It's a challenge everywhere you go with iCCM. And I'm sure for every country, the supply chain system is different and has different challenges. But because this is a healthcare strengthening system type of project, we needed to integrate and not create a parallel system. So we used the public pharmacy for drug management, and it was really challenging because of their capacity to be able to keep up with the management. But we, however, were patient. The capacity building part was, I would say those are some of the things that the pilot has shown that need to be worked on. And as UNICEF and even with Global Fund are coming along, they've taken this challenge up, and they're really looking into ways that that can really strengthen the supply chain system. As we've experienced, or as we've seen here, the drugs are not sometimes able to get all the way, to the community level, and even sometimes the health facilities go into stockouts. So that's one thing that we are working on the sustainability plan. Motivation of ARCOMs, motivation of community health workers. The project provided motivation, which was paid out or disbursed biannually. And a lot of ARCOMs would give feedback and say, this motivation, we need something that's more regular. What RACE did, though, it sparked a conversation at the national level that helped the Department of Community Development to come up with a strategy of how ARCOMs in Niger should be motivated. And they said, 50% is for partners, 25% government, and 25% community. Well, government and community have not yet met their end of the bargain, but like I said, now there is a coordination team, and these are some of the things that will be handled and be able to, and hopefully are pushed forward for action. I just wanted to read an encouraging quote from Ministry of Health, from the Secretary General, who was very instrumental in the startup of this project. And he says, in Niger, the RACE program led to a policy shift, and for the first time, the outcome started treating sick children. Now, children who live in RACE-supported areas don't risk death just because they have fallen ill with diarrhea, malaria, or pneumonia. And Niger will work with its partners to implement policies and secure the necessary funding so we can keep the momentum and continue saving children's lives. And this is by Dr. Maiga. I just wanted to share some recommendations with the community of practice here. From our experience, what we learned that nurturing political will is very important. We discussed, or we mentioned in the beginning, that there was political will. That's why even RACE came to happen. But we needed to nurture that political will. It was not easy in the beginning to implement this kind of project, which is actually an extension of the healthcare system. Sometimes there was a lot of pushback, but the technical committee that was put together, which comprised of Ministry of Health representatives all the way down the chain, really facilitated the nurturing of that political will. And this committee would meet biannually, and they would evaluate the progress of the project and saw how well it was doing, and it helped nurture and keep that political will alive. Another one of the recommendations I'd like to give is community mobilization is key for outcome acceptance. It's not always easy that a community health worker is accepted in their village, because people may say, well, when did you study? When did you go to medicine school to become our doctor here in the village? But what RACE did, RACE invested quite a bit of budget in mobilizing the community through monthly village meetings. And these village meetings were, they were led by the community health worker, but they were mobilized by the village chief. So that's why we saw such high level of acceptance rates in the community level. Another one of the mobilizations we did, we let the health districts spearhead or lead a mobilization which incorporated the mayors, it incorporated the village chiefs, the religious leaders, and we presented, or rather the health districts presented the results of this project to the leaders of the community, and helped them understand what good this was bringing to their community. So that has raised a very high level of awareness and acceptance of the community health work and of iCCM. So another thing is WHO's 2016 to 2030 Global Technical Strategy on Malaria recommends that national malaria programs expand iCCM as a way to accelerate progress towards universal access to diagnosis and treatment. So this underpins iCCM as a recommendable health project model for World Vision International as a whole. Thank you very much. Together, the battle against malaria, pneumonia, and diarrhea can be won, not only in Niger, but I believe in the world, where these three killer diseases are not allowing our children to live beyond the age of 5. Thank you again.
Thank you very much, Grace and Patsy. What wonderful presentations. And thank you, everybody, for all the awesome questions coming in the chat box. I am keeping my eye on that chat box so that we can get to it straight after Dr. David Zackett's presentation. David, give me 1 second, and I'll pass you the presenter ball. Thank you for joining us, and over to you.
Thank you very much, Sarah, and thank you so much, Patsy and Grace, for the great introduction and explanation of the project and the great results. Do I control the changing of the slides? Hello? Can you hear me, Sarah? Sarah?
Sorry, David. That was my audio going
Oh, okay.
a little bit wonky. I
Okay.
hear you, and you can move your own slides. So
Just,
the text box over the top of the slide, there's an arrow to the right. If you push the arrow to the right.
no, it doesn't work.
Oh, you know what? I see the presenter ball went back to me. So,
Okay. There. Okay. So good morning, good afternoon, good evening, everybody. And I have a very long name to this presentation. And again, thanks to Grace and Patsy for the great introductions. So what happened as this project was going along is that I was invited to join the project in about 2014, after about a year since the beginning of the implementation, and to take a look at the retention and motivation of the community health workers of the RCOM, the Relais Communautaire. And so we did some initial surveys of the RCOM, and we found that the most important thing for motivation and retention was some kind of motivated pay. They all wanted, mostly, not all, but a vast majority of them mentioned that they would need some kind of financial remuneration for them to be able to continue to do the jobs. Now, as Grace mentioned, the majority of the RCOM, especially at that time, were men, and many of the men would leave their villages every year for up to 4 or 5, even 6 months to go to neighboring countries to earn some money to bring back home to support their families, because as it was very clearly shown by Patsy, Niger is basically the poorest country in the world. It has the lowest of the human development indexes. It has the lowest per capita income. And as you'll see in a few of my slides, basically the entire country is desert. So it's a very difficult environment, and employment is very low. And so the men must leave their villages in order to sustain their families. And you also notice that they actually have the highest fertility rate in the world. I think Grace mentioned that it was 7.3. So various estimates are all in that area from 7.3, 0.4, 0.5 births per woman. And that makes Niger having the highest birth rate in the world. So not only is it a very challenging environment physically, socially, but also with this constantly growing population. And so it's a very challenging place. And also, which wasn't mentioned by Grace, was that the security situation in the country is also very shaky, and it makes it very difficult to move around and to visit the project sites. One has to have, especially when I visited as a foreigner, a serious group of bodyguards to protect us as we go about. And there is constant terrorist activity in the country from various angles, coming from Niger, coming from Mali, coming from up in Libya. And so it's a tough part of the world. And so we got going with the research on motivation and retention. And then the World Health Organization, the person who was in charge of all the race projects, said that they had some money set aside in the overall budget for research, and they identified supervision as one of the key areas of challenge for the entire implementation of the Community Health Worker Project, of the iCCM project. And this gentleman, he was very frustrated with never sort of any kind of advancement. And he challenged us all. And the RACE project was in 5 countries, and I'll get into that later, and Niger being one of them. And he was just so frustrated and wanted to have some innovation. And so I believe it in the beginning, and I could be corrected, it was actually he who suggested that we tackle the issue of implementation of a smartphone. Because as you probably all know, the use of technology is widespread, and it's kind of the flavor of the month sort of thing that everybody now is using their smartphones for everything in the West. And so why not use them for trying to improve health systems in the poorer countries. And
David, sorry to interrupt, but we didn't see a slide change. We're still on
no,
your
not
title
yet.
slide.
Still haven't got
okay, just checking. Sorry. I thought you were referring to a picture of man. Sorry.
No problem. So we got going then, and we took up the challenge of doing the research on the use of a smartphone by the community health workers. Now, globally, and including in World Vision, there have already been a number of implementations of the use of smartphones in health systems. And so these generally, though, have all been on a pilot basis, and none of them had ever been really studied. So we set up quite a large, all by the book, doing the statistical calculations and sample size calculations to do a randomized control study trial, an RCT, a randomized controlled trial, focusing and making it an operations research, which means that the research that we're doing is to inform policy and continued implementation of the project on the use of smartphones by community health workers to improve the diagnosis of the 3 diseases that Grace mentioned that are responsible for about 2/3 of all the deaths in under 5 children. And in 2 districts in southwest Niger, there's a bit of an error. So that's a very long title, but I wanted to make it long just so that you know exactly what we were doing. And so it was a clinical trial to see if the use of a smartphone can make a difference, a positive difference, in the diagnosis and treatment of malaria, pneumonia, and diarrheal diseases. And so we already saw, we see here where Niger is in Africa on the right side, and then the project areas which Grace already outlined, which are mostly around Niamey and the east of Niamey in the Dosso district is where the research took place. So we chose 2 of the 4 districts for the research. Here's a few of the key members of the research team. That's Grace on the right, and that's Mr. Ezekiel in the middle. He's a World Vision employee. He was the sort of the implementation field manager. And then Dr. Moyes, he is the representative from the Ministry of Health, and he is the director of the statistical unit in the Ministry of Public Health in Niger. And that's me on the left there. And then I also wanted to show you at the bottom here, amongst the children, is Johannes Yimbasalu. He is my research assistant who provided a lot of assistance to me. I had 2 or 3 research assistants over the course of the 3 years of the project, but he's the one who actually did quite a lot of the work towards the end with me, and he here visiting. And he's originally from Cameroon, so he was very thankful to actually be part of this and to learn about one of his neighboring countries and his brothers and sisters in Niger. This is flying either into or out of Niger, and so you can just kind of see that it is a very dry, arid country. This happened to be in February when there were the dusty winds coming in from the north, making visibility quite nebulous. This is just a normal street scene in the capital city of Niamey. This is the famous Niger River that flows through. It's one of the largest rivers in the world. It empties out into the Atlantic Ocean in Nigeria, but travels through quite a number of countries from its start in Guinea-Bissau in the mountains, and provides a bit of life to Niger in the south of the country in terms of some irrigation possibilities. This is just a view outside of my hotel window. You can see the river in the background. This gives you an idea of also the kind of environment. This was fairly typical temperatures during many different times of the year. I made quite a number of trips to Niger, and it often got into the 40s. And so it was a very challenging environment. And once one got into the villages, and understanding that people live without air conditioning or without any kind of cooling systems in 40-degree temperatures, one could see how even diseases can be exacerbated. So it was already talked a bit about the health system of Niger. Niger spends sort of middle of the road amount of money on health in terms of its percent of GDP, but its GDP is so very, very low that it actually works out to less than $30 per capita per year spent on health. That's contrasted to about $3,000. We actually spend about 100 times more per capita in Canada. And there they have one physician for every 50,000 population. We have one physician for every 300 or 400 population. And 91% of the population has poor access to health and sanitation facilities. Therefore, the iCCM project excuse me, is able to make the kinds of success that Grace showed in reaching the unserved villages with a reasonable type of health care. Population 17, 18, 19 million, highest fertility rate, birth ranked #1 in the world. Health, we already talked about, so I'll just skip over this. Grace mentioned all of that. So the overall project was to increase health services for children at the community level by training, as Grace mentioned, about 1,300 community health workers, or relais communautaires, as they were called in Niger. They all had about 8 to 10 days of training. So it makes a situation where we have a volunteer, and I noticed one of the questions was trying to make that clear, that these are volunteer members of the community who receive just kind of 2 working weeks of training. And so the results are even more startling when one thinks of the original input into them. So the research, as part of the larger WHO whole project on iCCM and NICeRAcE, and interestingly enough, that's the first time I've ever heard it vocalized as NICeRAcE. And, you know, in many ways, we're racing to try to achieve Millennium Development Goals and now Sustainable Development Goals. And I always tell my students, there is urgency, but there's no rush. And I think that by saying the NICeRAcE, it actually conveys a similar type of feeling that there is so much to do, but what's so important is that we take great care and make sure that the processes are done properly in order to achieve the end goals. So we do always work with under this sense of urgency and children dying. Doso and Duchi districts were chosen for the investigation, as already many had RCOM trained, and then 100 had already been given as part of the project a smartphone loaded with a specially designed application for diagnosis, treatment, and drug material supply. So the focus on the care is on the children ages 2 to 15 months, as mentioned, suffering from malaria, diarrhea, and pneumonia. And so the RCOM were considered our analysis unit in the study, and we did a sample size calculation. And so 66 of the RCOM of the 100 were randomly selected for the intervention group, and 64 were assigned to the control group. So we had 130 RCOM in total. We wanted to have exact same numbers, but some dropped out, and so this is what we ended up with, but it was still excellent. And the sample size calculation was done by the normal statistical analytical way. And so we were a bit daunted at first because it was such a large study. But once we got over that, we just hit the road and started implementing. So the intervention RCOM were trained in the use of the smartphone loaded with the application, which was designed and developed by Dimagi. It's a company, it's a social enterprise based in South Africa, Senegal, and California, I believe, that World Vision uses for quite a number of projects. They have open source access to many of their products, and so we had them adapt their open source product to this particular project, and so the phones were loaded and 66 phones were given to RCOM to assist them in their diagnosis and treatment of the children. So we chose, according to the statistical sample size calculation, 4 children per RCOM. And so in overall, we had a sample size of 526 children that were, so 4 children per RCOM being presented to them in their routine work. And so what we did was, in half of the group, the intervention group, we measured and tried to measure the effect of the smartphone by using a large questionnaire, various observations, interviews with the RCOM, and interviews with the caregivers. In almost all cases, I believe it was 88%, the caregivers were the mothers. And the sick children were all reassessed by a professional clinician immediately after the care treatment scenario. So the child would present the two professional clinicians. They traveled in pairs. They would show up in a village, and they would go visit the RCOM, and then they would wait until a mother or a caregiver comes with a sick child to the RCOM, and then they would observe, and then they would do a total reassessment of the child afterwards to see whether the RCOM did a good job or did not do a good job. And so we had measures on various the parameters related to all three of the diseases about the care given by the RCOM. And the data were entered into an SPSS and analyzed. They were data were entered directly into tablets, tablet computers right on the spot, and then downloaded up to a cloud. And so we had on-the-go assessment of the data, and so we were able to track things as they go along. And we were also able to clean up the data on a very regular basis and an immediate basis to make sure that the data were complete and valid as we went along. So the results of the two groups were afterwards compared, conclusions and recommendations were drawn. And so the data collection took place over an 8-month period in 2016. So what we did eventually is to be able to compare the intervention with the control group is we developed a quality of care variable. There was no existing standard measure that fairly or accurately reflected the responsibilities and challenges of the RCOM. So we developed a custom score for the RCOM assessment, and it simplified analysis, reporting, and communications while capturing key aspects of the care. And the quality of care variable was developed specifically to the job responsibilities of the RCOM, so it was unique to our study, and the score was a composite result of both assessments, diagnosis, and treatment outcomes. So it covered all the issues. Sorry that these are a little complicated slides, but the quality of care score was developed on the basis that the quality of care could be scored at 100% for each of the cases, regardless of the diagnosis and treatment, whether there was a sick child or the treatment or the diagnosis was not serious. And a perfect score was achieved when each of the 10 screening questions, so we had 10 different variables as part of this composite quality of care score, and each of the red flags, and a red flag being a danger sign, when the child presented with certain danger signs, or when the danger signs were correctly identified, regardless of whether they were present or absent. So we gave the RCOM a good score if they identified a danger sign or if they identified that a danger sign was not present, and so that being a correct diagnosis. Also, secondly, there was a scoring according to the referral or non-referral made according to the presence or absence of a red flag. Thirdly, that each of the medications were appropriately administered based on need. Now, they had with them in their kit, they had antibiotic, amoxicillin, they had oral rehydration salts, they had zinc, and they had artemisinin combination therapy for the diagnosis, for the treatment of malaria, and they also had rapid diagnostic tests for an immediate on-the-spot diagnosis of falciparum malaria. And so we wanted to see whether they were using these treatments correctly or not, and then also a final variable was added about the advice given to the caregivers. So we put those 4 different types of things together and we came up with a composite quality of care score. So the choice of score non-events was made to avoid any distortion of results by cases where there was no evidence of serious illness. So we were able to cover whether the child was really sick or not so sick, and this was determined appropriate given that it is just as important for the RCOM to identify illness and administer care as it is to rule out illness and not provide the wrong care. Because as you know, there is often a propensity to provide drugs when drugs aren't needed. And we wanted to make sure, especially with the administration and use of antibiotic, because there is great global concern over resistance developing to antibiotics. And there are people who believe that community health workers should not be given antibiotics to use. And so we chose, though, to use antibiotics as part of the overall project. And we also have another section of results that I'm not going to report on today, but show about the use and the proper use of the antibiotic by the ARCOM. So this is a rural scene here in Niger, very, very common. It's very arid, very dry. This is one of the villages. You can see it's pure sand. The houses, all the structures are made of sand blocks. And here's some women going out collecting and delivering food. This is at one of the meetings when we showed up in a village. The entire village basically would come out to meet us. And as Grace mentioned, that one of the most important things was community mobilization. And this was all part of it, meeting with groups of the women, meeting with groups of the young people. Here they are, young girls out collecting water from the well, and also with the men and the elders of the community. It's a very patriarchal society. The gentleman in the red he just left World Vision Niger, but he had been with World Vision for about 10 years, Dr. Nrawa. He is the head of all the health projects and nutrition programs in the Niger office. Here we are with the chief of the village and some of the other elders. And the person on the right is Dr. Moyes from the Ministry of Public Health. And generally, at least in my experience, we were always extremely well received by the villages, and we were treated so well. And in fact, visiting the villages was personally some of the greatest experiences of my life. I have been working in over 45 countries around the world, and mostly all community-based. And this project really moved me, and working with the communities. This just shows the map of Dosso district and a distribution of all the different community health centers. So you can see it's fairly evenly populated, and we were able to select a random sample of the health centers for the project. Here's Mr. Ezekiel with one of the community health workers providing some advice. Here is a community health worker treating a child brought by the mother in the red. And here you can see the community health worker using the smartphone to follow along and enter the data as she, or he in the case, asks questions. And the kit, the box at the back is the box with their balance to weigh the child and all their different drugs and treatments with the zinc and the malaria drugs and the ampicillin and the oral rehydration salts. And so you can see that was the type of phone. It was a Samsung phone that the ARCOM used and went through an algorithm through the app to diagnose first and then to treat the child and refer if necessary. So generally the results. Overall, there were some detectable differences between the intervention and control groups on most of the variables measured. But most of these results were not statistically significant. But where it was significant was that the ARCOM with the smartphone did better in several areas, and in particular scored 5.2% higher on providing better overall quality of care when compared to those of the control group. So they also better screened for and identified the 4 main danger signs in the sick children. They better detected swelling of the feet, they better advised the caregiver in cases of diarrhea, and they did somewhat better on identifying cough, correctly treating and referring to a higher level when needed, referring when danger signs, prescribing one of their dedicated treatments when needed, and had more caregivers able to explain back the drug dose and administration after treatment. But most of these differences were not statistically significant. The only one that was really truly statistically significant were the detection of the 4 main danger signs. Specifically, the quality of care provided by the intervention group was slightly better when compared to the control group. This significant difference was very small, but indicated that the use of the smartphone by the ARCOM did have some impact on the quality of care. This difference, though, appeared to be related to the health screening process, with the intervention group using the phone, asking one more question on average than the control group. Now, we were able to detect this significant difference because we had a very large sample size, 520 children and 130 RCOM. However, there were also a few areas where the control group did better, as in properly detecting fast breathing, which is a symptom, a possible symptom of pneumonia. Referral, however, had the poorest performance according to the quality of care score, and that was general over all the RCOM. Of all the 226 cases that needed a referral based on at least one red flag, or the red middle upper arm circumference tape to measure malnutrition, 197 of the cases showed missed referrals. So we're still a little perplexed as to why so many of the referrals were missed. The control group missed 93% compared to 85% in the intervention group. And there was a moderate inverse relationship seen between the distance and the referral subscore, suggesting that there was a greater likelihood of referral with farther distances. So it seems that those RCOM that lived closer to a community health center where there was a nurse didn't refer as much. And the RCOM who were located less than 15 kilometers from their supervisor provided better quality of care compared to those who were greater than 15 kilometers from their supervisor. So there's quite a lot of information that we got out of this. And whatever the considered danger signs, the proportion of children examined for the danger signs was higher among the RCOM using smartphone than those that did not, as I already mentioned. And the differences are all statistically significant, which could be attributed to the RCOM of the intervention group being more attentive and following procedure when looking for existing general signs than the RCOM of the control group. So it did seem that the smartphone, by having a step-by-step procedure, led the RCOM to ask all the questions about the danger signs. And of course, asking about the danger signs is one of the most important parts of the diagnosis component of the care episode. I've got some, but the 4 different danger signs were convulsions, the incapacity to drink or eat, vomiting everything, and then checking for lethargy or unconsciousness. And you can see the differences where the RCOM with the smartphone did better, and all were statistically significant under P equals less than 0.05. The most frequently missed danger sign were chest indrawing, rapid breathing, and fever. The intervention groups showed a greater likelihood of wrongly identifying chest indrawing, while the control group was more likely to miss this danger sign. So here we even have mixed bad results, if you will. One showed a greater likelihood of wrongly identifying it, while the other one was more likely to miss it. And then cases with multiple danger signs, multiple red flags, accounted for 35% of all cases. So this means that the child was presenting with possible malaria and pneumonia at the same time. And the presence of multiple red flags indicated a greater illness severity, and the RCOM were in general more likely to refer these sick children to the health center. So the sicker the child, the more likelihood of a referral. And we're not sure why, so further up study is needed as to find out why they weren't referring as much. But furthermore, the smartphone had an influence on medication administration, with less wrong administrations occurring with malaria treatment when the smartphone was used, and other treatments showed no difference. We're just getting towards the end. Here's one of the World Vision staff working with the RCOM on the left. The RCOM, as you can see, were all provided with a name badge and also T-shirts and things like that to help build their culture. And so in analysis, we used SPSS and STATA software, and we had many variables. This had quite a lot of challenges in terms of the analysis, but it was all very interesting. Our focus today is mostly just on the quality of care. That was the main outcome variable that we were interested in, but I also mentioned we also did analysis according to supervision and treatment. And we had the full collaboration of the Statistics Division of the Ministry of Public Health. I hired 2 biostatisticians here in Toronto to help out, and various of the staff and researchers were also involved. And the staff in Niger were all fantastic. And so conclusions, the overall quality of care by all of the RCOM, both groups, which covered health screening, correct identification of the danger signs and other red flags, correct treatment and drug use, and advising caregivers, was high. So to me, this is one of the greatest findings of the study, even though it's not focused on the smartphone, but the RCOM were providing good care. And as Grace mentioned in her presentation, there was huge faith in and trust in the RCOM given. And this could be part of the reason, is that they were actually doing a very good job. And they're doing a very good job in very tough circumstances. And so the smartphone intervention group showed a statistically significant quality of care improvement of 5.2%. You know, really not too high, but somewhat. The difference appears to be related to the health screening process, with the intervention group asking 1 more question on average than the control group. The intervention group tended towards more complex cases with more than 1 symptom, which may have influenced quality of care. However, when we did a statistical testing, that it showed no differences between the intervention and the control groups of children. So that could really be ruled out. The referrals being made do not appear in practice to follow the guidelines that a referral is required when 1 or more red flag or a red middle upper arm circumference tape is present. Furthermore, other factors may be influential, with distance from the health center being one. It is also unknown if the health centers would be able to accommodate the number of children that would occur if the above criterion was strictly adhered to, or if they were amenable to receiving referrals and providing good and respectful services. If the RCOM believe that there is a capacity or negative issue at the health clinic, they may be introducing their own decisions, their own heuristics as to who is referred. Ultimately, the smartphone use may be a good strategy to counter outside influences on referrals once they have been defined better and followed better. So the actual algorithm for referral was not well followed. And it should be noted that overall child vaccination rates were discovered to be very low. This was just a side feature, a side finding, that with only 60% of overall vaccination rates in both groups, though data were missing in about 20%. And this is perhaps fault of the smartphone application and iCCM in general. Now, iCCM is only concerned with pneumonia, diarrhea, and malaria, and not the other vaccine treatable and preventable diseases. And so it may be an issue for future implementation of iCCM to include vaccinations. And generally, the intervention RCOM were a bit more motivated, but assessed as more difficult to retain. So that was interesting. They were a bit more highly motivated, perhaps because of the use of the smartphone and the smartphone giving them some type of status in their community, where even cell phone use is low in these communities, a very poor country. But they were more likely to say they weren't going to stay with the project much longer. Finally, all the RCOM delivered relatively good quality of care in very challenging environments. This is encouraging. While smartphone use contributed to some improvement of quality of care, we can be confident overall in the work being done by the RCOM, though there remains various areas for improvement. Recommendations can be made on the future use of smartphones and overall deployment of community health workers, emphasizing continuing education, building organization culture, and providing consistently good supervision. Just to flesh those out, and this is, I think, my last slide, that all the RCOMs would greatly benefit from regular and periodic continuing education, with each session concluding with an evaluation and periodic assessment of their educational needs. They exist in a situation where they're very isolated. Even some of our clinicians in going out to the villages got lost. And so they're way far away from the towns. And generally, the community health worker organization culture is weak, the world over, not just in Niger. So emphasis needs to be placed on values and belief, rites and ceremonies, symbols, myths, stories, heroes, and cultural health networks like conferences, meetings, even newsletters or whatever, and perhaps further use of the smartphone. And providing consistently good and regular supervision is so important. This, I think, is perhaps, for me, one of the greatest findings of the entire study, is that this is an area where any future implementation of iCCM, there should be emphasis put on the supervision. So I'll end there. Thank you very much.
Wonderful. David, Kathy, Grace, thank you for wonderful presentations. And there have already been congratulations in the chat box. We celebrate with this entire and expanded team on the success of this work. And there are a lot of questions in the chat box that I'm just going to dive right into with this group. Before we start with the first couple of questions, just a reminder to keep typing your questions and comments in the chat box. I'll keep my eye out for those. If you have a comment or question that you feel, is much better spoken, please use the raise hand feature. The raise hand is a little icon of a hand. It's probably to the right of your name in the participant list. In some versions of WebEx, it's below the participant list. I'll also try to keep my eye out for that. All right, so questions we have coming in are some clarifications on the diagnosis and treatment rates. We've got some questions on CHW supervision and retention, as well as some questions around the app. So I'm going to come back to some questions for Grace. Can we go back? This is a clarification on defining the treatment rates for the three diseases we were looking at. The treatment rate we were seeing is malaria rate was 64% compared to pneumonia at 74% and diarrhea at 98%. Do these treatment rates you presented, does it also include diagnosis? And is the number diagnosed positive for the disease the denominator as opposed to all people seeking care? So, and in this rate you're doing is, what's your denominator that you were using to calculate the 64, 74, 98?
So to clarify on the denominator used to calculate the treatment rate, it's all those seeking care with the symptoms defined. For example, for malaria, it would be those coming in with fever. For those with simple pneumonia, would be those coming in with cough and or difficulty breathing. And diarrhea is, checking how many light stools they've had. So the denominator is all those seeking care with the symptom defined. And then, of course, like I mentioned, the numerator is just those who received treatment regardless of outcome. Great.
Were there interventions for prevention as part of NICeRACE? And if so, how are those prevention interventions measured?
Yes, they were prevention interventions, and what was given to the ARCOM is what we familiarly know here in Niger as the 8 essential family practices, with 8 different topics, which include, infantile, young child feeding practices, exclusive breastfeeding, hand washing. So it's 8 topics. And when we talked about community mobilization, the monthly village meetings actually comprise of a discussion of one of these topics each month. So yes, that was a prevention intervention.
And were those topics developed solely by World Vision, or also, or was it in collaboration with the Ministry of Health? One of the questions here was around what Ministry of Health tools were used.
Okay, so I'll answer that in 2 parts. For the prevention or the health promotion document or module, that was developed a while back by UNICEF and Ministry of Health. So, you know, we just used a document that was already existent. And then for the documents for the RCOM, you know, the register, the medication drug sheet, referral form, all of those were developed during RACE, but Ministry of Health, WHO, and World Vision elaborated those with a reflection of what Ministry of Health was already using, and so they tweaked that and developed documents for RCOM in the beginning of the project in 2013, and those documents were validated.
Thank you.
Yeah.
Thank you. So I'm coming back up here. Everybody was quite impressed and surprised by the CHW percentage of trust in the community. That's really great. And you're going to how that trust was fostered within the communities. How were the RCOMs in Niger recognized by medical facility staff? How was trust built, and what was trust relationships like with the official medical staff?
Yes, initially, you know, I mentioned about some of the pushback the project received, you know, from MOH, just because there was little trust that people with an education level that's not so high could treat people in the community and do it well. But a strategy that was in this particular project was the supervision and the monitoring. We included monitoring, mandatory monitoring and supervision by Ministry of Health themselves, so that the national level would go out to the field annually to see the RCOM in the village, and they would draft a report on what they found. The regional level would go out and even hold coordination meetings. So the district level had a supervision or monitoring every 3 months. So with time, they built a rapport and an admiration of what the RCOMs were doing. So it came with time, but 2 years into the project, it was already established.
Great, thank you. You answered the supervision question as well, so wonderful for that. There are a couple of questions here. We'll get to those after this. There are a couple of questions here around referrals and success around referrals. So I'll ask them both. And so the first question is, the iCCM approach in Niger delivers services to remote communities located more than 5 kilometers from a health facility. So what was being done to ensure those severe cases were referred? And the second question related, were sociocultural factors that are barriers to accessing health services, were there interventions around breaking down those sociocultural barriers as well? Okay,
I'll start with the referral question. The RCOM is instructed, you know, to make referrals under, you know, certain parameters. So, and then there is a reference form that has to be filled for the caregiver to take to the health facility with them, and a part of that health form needs to be brought back. So after the health care agent at the facility has seen this patient who's been referred in and has filled out what has been done and what needs to be the follow-up, that form needs to be given back to the caregiver and brought back to the CHW. So in the beginning, that that counter referral, system, that form, it was challenging to keep up with that. But with time, as we went out for supervisions, as coordination meetings were being held at the district level, the emphasis of making sure that form is brought back to the ARCOM, and so that ARCOM is able to trace in their register that, and even through their follow-up, that this caregiver actually took their child to the center for the referral and brought them back. And looking at the household surveys, we see that that was quite effective. And then moving on to the socioeconomic barriers, that was also taken care of with the health promotion. I'll give an example of two things. Diarrhea. We noticed that care-seeking behavior for diarrhea was quite low. And with just a few interviews, we found that the mother sometimes does not see diarrhea as a big deal. It's just a soft, soft stool. But some of during the health promotion monthly meetings, when the topic of signs of childhood illnesses, that was put emphasis on. Communication was taken down to the ARCOM, that mothers need to understand when there is a watery stool, this child needs to be taken to see the community health worker immediately. And then malaria, with the fever and sometimes convulsions, that's sometimes perceived as, maybe a spiritual problem and not, a medical problem. So awareness was brought through the health promotions, through the signs, teaching about signs of childhood illnesses, and that, of course, increased. We saw the care-seeking behavior numbers, which spoke to how much that increased.
Thank you. I have a question here for you, Dr. Zakis, on do we have an estimate on the percent of the ARCOM in the intervention group who used the app regularly?
Yes, we know that they all used it regularly. They used it for every episode with a sick child that would come to them.
Great. Polly, do you want to unmute and ask your question? Polly, you're still muted. Oh,
hi, everyone. Can you hear me now? Okay. Yeah, no, thank you so much. It's really good to see the results of this. And I was thinking, as part of our entire World Vision initiative into iCCM, then one of the few really, really good ones that I can see. And that following people approaching the quality standards. I would say Niger was the one place where that was really well taken on board. And Grace, this is probably before your time, but we did a review 2 years ago of the value of iCCM project model. I think that our conclusion was that the project model as a concept make iCCM almost impossible for any deployment outside a grant-based program like Niger. But it's really good to see this as a positive positive result. So yeah, one of my questions was on uptake, and one was the question was this referral compliance that was an issue, or making the referral itself? And the second issue was we did a lot of work around the design of follow-up applications, so that the app would actually send reminders to the CHW that within 48 hours they were supposed to do a follow-up visit. Did you have any results around follow-up compliance? Thanks.
David, do you want to try the follow-up compliance or Grace, either one?
Yes, I'm sorry, I don't know. I only know about the study.
I think Paul, she's talking about the study about the mHealth application when she's talking about the reminder to follow up in 48 hours. So that information we can look into and give it to you at a later time with more detail and clarification.
And Polly, sorry, Polly, will you recap quickly the first part of your question? And I missed it. So sorry, recap that first part of your question.
Well, it wasn't a question so much as a sort of recap of our iCCM journey, because we developed a huge suite of tools. The uptake of those in Niger was really high, so it's great to see a positive outcome from tools that World Vision sort of co-developed with the team and the ministry there. But in terms of Grace's comment about what this implicates for iCCM as a project model, the funding structures within a project model ADP format aren't adequate to support iCCM at this kind of level. And what we learned was very much about it's important to do that in a grant setting where you've got end-to-end support for iCCM.
Thank you. Thank you for the clarification. How about we have, I see we're at the bottom of the hour, but John has been patiently waiting with his hand up. So John, why don't you take the last question and unmute, and it's over to you. Oh, but now I see your hand is down. So maybe your question, you don't have the question anymore. Sorry, everybody. All right, we are at the bottom of the hour, and so I just want to say thank you so much again to our speakers for leading us through this presentation. And as we say in the chat box, there is continued funding being sought to continue this work, and there's also publications coming out soon around the NICeRACE work that we will, of course, share through the global health community of practice as they are available. Just a few announcements as we close out. As always, we are looking for national offices and different programs to present at our community of practice. I'm working on getting these dates in March pinned down, but you'll get those invitations in your inbox soon. If you have a program you would like to nominate for a health community of practice WebEx, please send that to me via my email, which is there on the screen. And with that, I just want to say we will get these resources and recording up on WV Central in the next couple of hours. And thanks everybody for participating, and we'll see you on the next WebEx.
Thank you very much, everyone. All the best.
Thank you, too.